Well, hello everybody, and welcome to this new UEG webinar. Our topic today is going to be positioning therapies in inflammatory bowel disease. My name is Ignacio Catalan-Serra, and I'm a gastroenterologist and I do IBD, and I'm talking to you from Levanger, Norway. And I want to thank UEG for the invitation to moderate this session today. And I want to thank you also to take the time and for being with us tonight. So luckily for our patients, the therapeutic options that we have for to treat inflammatory bowel disease have expanded a lot in recent years. And after the introduction of anti-TNFs in the early 2000s, which was a major breakthrough, new biologics and small molecules have been adopted and accepted in the clinical practice in the last, especially 5 years. So actually, thanks to the work of many labs, we got to understand better the pathophysiology of the disease. We got to understand better the different pathways that lead to inflammation. So we were able to identify new targets to improve the quality of life of patients. So these new treatments are useful, both for primary treatments in treatment failure and loss of response, for example, to infliximab, which is a scenario that was very needed. So I guess that our challenge today is going to be to integrate these new therapies in the current algorithms and in the drugs that we've been using for a long time, and try to personalize the treatment as much as possible, although this is very challenging in inflammatory bowel disease, as you know. But it's more and more important to try to use the right drug for the right patient at the right time, which is obviously challenging. So for this task, we are very happy to have today two leading experts in inflammatory bowel disease. You probably all know them. And I will introduce Krisztina Gecse from UMC Amsterdam. Hi, Krisztina.
Hi, hello, good evening, everyone.
Hi, welcome. And Peter Irving from London. Hi, Peter.
Hi, good evening, everyone. Nice to be here.
Thank you. Thank you for joining us. I'm just going to say a couple of words about the structure of the webinar. I think we're going to be a bit ambitious, and we're going to take both inflammatory bowel disease as a whole, so both ulcerative colitis and Crohn, which might be even more challenging. And I guess Krisztina and Peter prepared like a tandem talk. So there's going to be only one presentation that they're going to share. And we might be able to discuss along the way to make it as dynamic and practical as possible, because I think that's the objective of the webinar today. So yeah, just to encourage you to write the questions in the chat function that you can see down there, and eventually comments as well, because this is an area with a lot of gray situations that might need some expertise, and it would be very great to have the input of everybody on the other side, and I'm sure there's a lot of expertise there. So I guess the technical things are okay. It's 18:33 in my watch, and we have like 152 people online already, so that's very nice. So I think looking forward to start. And Krisztina and Peter, the floor is yours for the presentation. Thank you.
Thank you very much, Nacho, for the kind introduction. And it's indeed a great pleasure to be here with you today. So we are going to talk about positioning treatments in IBD. And indeed, you are very much welcome to ask questions. And we are going to try to take them during the presentation, as well as after the presentation during the discussion. So these are our disclosures. And the learning objectives for this evening is to understand which treatment options are appropriate for first-line advanced therapy in ulcerative colitis and in Crohn's disease. So we are talking about biological treatment and small molecules, and how to choose between them, and also to review available evidence which treatments are appropriate for anti-TNF failures in IBD, and then how to choose between these treatment options. So we have seen an explosion in available treatment options for IBD, and this is just a quick overview of the currently available treatment options as approved by the EMA. You can see the anti-TNF molecules in the first line, and then the year of approval, and then more recently vedolizumab and ustekinumab came to the market for both indications, and tofacitinib a couple of years ago for the indication of ulcerative colitis. So how to decide between all of these treatments and how to choose the optimal order of these treatments in one specific patient. And then, of course, there is the optimal case scenario. If we could predict which patient would respond to each treatment, then we wouldn't lose any time with choosing one after another. And there have been undoubtedly previous findings and studies investigating response, especially to anti-TNF treatment. However, if you look through these studies, there are a number of limitations to consider. And that's mostly the assessment of response and remission, so your gold standard of definition. And in most of the studies, these are, for the moment, investigator dependent, and mostly they are defined by clinical criteria, so not by objective endoscopy criteria. They operated with relatively small sample sizes, and then some of the studies also lacked the TDM and the drug exposure. So all in all, I think what is now reality is really the trial and error approach, and we can hope that that in the not too distant future we will also have some more additions to the optimal case scenario when we can predict the best treatment already before starting treatment for our patients. So so then how to decide on the optimal order of using these treatments? Well, on the one hand, we are taking a look at comparative efficacy and safety, and what are the studies that we have when we are taking a look at comparative efficacy and safety. Well, we have a meta-analysis. So these are integrating findings mostly from randomized controlled studies, and they are applying objective statistical formulas. However, any meta-analysis is just as strong as the weakest randomized controlled study or the weakest study that was included in the meta-analysis. Then secondly, we have the real-world data. So routine collection of patient data from many sources, such as safety registries, respective cohort of patients. And then thirdly, and most recently, the head-to-head trials, which is really the gold standard, which are designed and powered to allow formal comparison between different treatment options. And just to show a few examples of this, how these head-to-head trials are really coming up in the near future, that you can see that in IBD there are quite a few running. Some of the results of the Gardenia and the Hibiscus studies are already out. The results of the CView are expected to come out at the next congresses. And you can also see, for example, the Galaxy study, which is comparing guselkumab, ustekinumab, and placebo, which is expected to come out in a few years. So you can see that the number of head-to-head trials is really increasing in the coming years. So we will have higher evidence. And then I think the second perspective, if we take a look at our everyday practice on how to decide an optimal treatment order, besides comparing efficacy and safety based on the trial data that we have, is really patient profiling. And then we take into consideration the age of the patient, the extraintestinal manifestations, the comorbidities, if the patient is pregnant or would like to become pregnant, and if the patient has perianal disease. But we'll come back to this patient profiling a little bit later. And then there are also some other aspects, such as patient preference, costs, drug availability, national reimbursement strategies, infusion unit capacities, and probably many others that we all take into consideration when we choose for one treatment or the other. But these are so country-specific and maybe even center-specific that we are not going to go into these aspects. So we are going to focus on comparative efficacy and safety, as well as patient profiles. Peter.
So thanks, Krisztina. So in fact, we're going to start with the area probably where we have the best selection of evidence available, and I'll sort of speak about some of those things that Kristina's just taken you through. And that's the area of ulcerative colitis in first-line choice in the sort of conventional therapy failure patient. So we have a huge number of drugs now available here compared to what we had 20 years ago. We have 3 different anti-TNF agents, infliximab, adalimumab, and golimumab. We have vedolizumab. We have tofacitinib, and most recently, ustekinumab has been licensed in this indication. So how on earth do we make those decisions about which drug to use? So one of the areas of evidence that Krisztina mentioned was real-world data, and I am presenting this study knowing that Professor Mansaris, who is the senior author on the paper, which I think has just appeared online in JCC actually, is in the audience now. So I'm going to have to make sure I present it accurately. So the trouble, of course, with real-world data when you're comparing 2 different drugs is that there may be many different reasons why, as a clinician, you may choose one drug or another. And that, of course, might bias the outcomes in those patients who are being treated for a specific condition. So I don't know, you might say, well, this patient's got really nastily active in ulcerative colitis, so I'm going to go for intravenous anti-TNF here because I think that's the best choice. And in another patient where it's less active, you might go for subcut anti-TNF, or you might think I'm going to go for vedolizumab here. One way of dealing with that is to try to create matching in these cohorts using something called propensity score matching, actually first really publicized in IBD by another cohort we'll look at in a moment. But basically, it uses a matching of individual characteristics of the patients in the different cohorts, and then applies a weighting called inverse probability weighting to try to make the cohorts as close as possible. So this collaborative study here between Canada, Greece, and the United States looked at a reasonably large cohort. You can see nearly 180 biologic naive patients who were receiving first-line biologics, and they compared vedolizumab with anti-TNF as a whole. So that was a mix, of course, of both intravenous and subcut, and indeed both adalimumab and golimumab in the anti-TNF cohort. And what you're seeing here is the outcomes on treatment persistence. And you can see, if you look at the red line, that treatment persistence with vedolizumab was better towards the end of the 2 years than it was with anti-TNF. And over on the right-hand side, looking at the bar graphs, you can see exacerbations of ulcerative colitis were more likely with anti-TNF, and indeed, perhaps unexpectedly, serious adverse events were more likely with anti-TNF than with vedolizumab. Interestingly, in fact, in terms of efficacy at the end of 24 months, there wasn't a huge difference, but there was some suggestion here that in this cohort of naive patients, there were some benefits to vedolizumab. And I perhaps won't go into this, the Victory Consortium, in great detail, other than to say that this was a very similar study, also very recently published, but first presented a few years ago. And it's a collaboration amongst American centers looking again at first-line treatment with anti-TNF and vedolizumab, and a little bit like the last cohort we've just looked at. There was some suggestion in the TNF-naive cohort that there was some benefit perhaps to using vedolizumab here. So that's real-world data. But as Krisztina pointed out, that's not the only data we have. Instead, you can look at head-to-head studies. So this study, I hope you're all familiar with. It's Varsity. It's the first good biologic head-to-head study that we've seen in inflammatory bowel disease. And this was a cohort of patients who were randomized either to receive vedolizumab or adalimumab. Now, they weren't actually all anti-TNF naive. I think about a quarter of patients were allowed to be anti-TNF exposed, and we'll look to see if those cohorts behave differently in a moment. But a large group of patients here randomized to receive either vedo or adalimumab with follow-up initially to 18 weeks, and then out to a year, with the primary endpoint being clinical remission. And then you can see that there were some secondary endpoints of mucosal healing and discontinuation of steroids. So what did it show? Well, if you look over at the left-hand side, there is the overall primary endpoint, and you can see there that more patients receiving vedolizumab were in remission at the end of a year than adalimumab. And if you look over to the right-hand side, we see it split there by whether they were anti-TNF naive or anti-TNF failed. We're concentrating in this section of the talk on the anti-TNF naive, and you can see again that there was a difference there, a significant difference, whereas in the anti-TNF failure group, that was less obvious. So there's a head-to-head study, what you might describe as the gold standard. Again, perhaps a suggestion, as one might expect, that infections were less common in vedolizumab-treated patients than in adalimumab-treated patients, although, let's be fair, both drugs tend to be very well tolerated. And then finally, just a word on meta-analysis. So the meta-analysis we're particularly interested in when we're comparing different drugs is network meta-analysis. And what that means is that we use the placebo group in each trial to anchor the effect sizes that we see with each of the drugs. So of course, they are very different studies, but it's a way of trying to normalize to placebo. And you can see here on the left that placebo is the sort of the big circle in the middle, and that each of the spokes that comes out is each of the different drugs, the size of the circle being the number of patients in the network meta-analysis who've been treated with those agents. And then, of course, most interestingly of all, you can see here that there is a comparator study. So there's a line connecting adalimumab and vedolizumab, and that in fact strengthens the whole network of the meta-analysis. Over on the right-hand side, you can see the sucrase, which is basically a measure of how effective a drug is. It stands for surface under the cumulative ranking, I think. And this is looking here both at endoscopic improvement, that's the dark bar, and clinical remission. You can see in this network meta-analysis, infliximab, first line comes out as best. You can see Vedo being sort of probably just peaking the others, with adalimumab being the least effective. I think you do have to take these network meta-analyses in the context of everything else we know. And as Krisztina pointed out, you have to look at the different trials and understand that in some ways, even with that anchoring to placebo, they are different. And so one can't necessarily say we therefore know drug X or Y is the best. But those really, there's if you like, practical examples of assimilating the different forms of evidence that we have that help us to make decisions on which drug we're going to use in a given situation. Krisztina, what about second line treatment with UC?
Thank you, Peter. So indeed, second line treatment. And there was one interesting question. Maybe we should just come to that I could see in the chat coming by as you were talking about first line treatment, which was asking, well, should we be moving away from the concept of first line treatments and second line treatments and call it personalized strategy or individualized patient pathway? Do you have, what's your view on that?
Well, ideally, I think the answer to that has to be yes, doesn't it? You know, we certainly ought to be thinking in an individualized setting. The difficulty is, of course, we can't do that at the moment because we're just not very good at doing it. And in fact, the things that does differentiate patients greatly is whether they are first line or second line. And by that, we still really mean actually pre and post anti-TNF, I think, in the vast majority of cases, don't we? So yes, I think looking forward, that's right. But nevertheless, I think when we're thinking about things in the current era, it is still a useful way to think about things. I don't know. Do you think that's fair, or do you see it differently?
Yeah, I think it's very fair to say, and this is what I said, I think in the first slides as well, that we are hoping that it's going to change in the not too distant future, that we can truly predict response to treatment, and then we can actually talk about a personalized treatment. And I think for the moment, just for the sake of the practicality, we were sticking to first line, second line, or anti-TNF and anti-TNF failure, because that's what we would mostly see in our everyday practice as well. Just like said, we still do sort of a trial and error approach according to our best patient profiling, and that's the evidence that we are trying to review actually during this talk as well, how to make these choices so that it can be, to our current knowledge, it can be as individualized as it can be at the moment. So when it comes to second line treatments in UC, then really we can still have quite a few options as listed here, and there are a few studies looking at post hoc analysis of the big randomized controlled studies. So here we are looking at the post hoc analysis of the Gemini study. And then this post hoc analysis and these graphs are looking at the UC patients who actually achieved the composite score of rectal blood loss and of 0, and the stool frequency of score of 1. And then what you can actually see on the graph, and this is really the induction phase during the Gemini study, that there is a significant difference between all at all time points, actually, between placebo and vedolizumab. And then comes the interesting part, that if you divide these patients as TNF antagonist naive and TNF antagonist exposed patients, then you still see a significant difference at all time points between the patients who were TNF naive, anti-TNF naive. However, this difference diminishes in the population who were anti-TNF exposed. So I think that's a nice illustration that that vedolizumab actually might work slightly better in the anti-TNF naive population. And then on the line of this, so if we look a step further with ustekinumab in ulcerative colitis, then we take a look at the data from the UNIFY study, so the big randomized controlled study for UC patients with ustekinumab. And then here, once again, if we take a look at clinical remission as the endpoint, and then we separate the patients who were biologic failures or non-biologic failures, and then most of these patients were actually bio-naive, then you can see that in terms of clinical remission, there is still a significant difference at week 8. So we are still looking at induction data for those patients who are receiving ustekinumab as a second-line treatment or let alone third-line treatment. As well as there is a significant difference for those patients who were bio-naive. So if we, and once again, we can't really compare the randomized controlled studies, but it seems that with vedolizumab, we saw a diminished action in anti-TNF pre-exposed patients. However, here we still see a significant difference, and you also can't really appreciate much of the difference in terms of the deltas in inducing clinical remission. And you see actually the same tendency if you evaluate clinical response or endoscopy healing. And then let's take a look at tofacitinib. We also have an OCTAV post hoc analysis paper. So OCTAV was the big randomized controlled study for the approval of tofacitinib in UC. And here we are looking at the induction studies of OCTAV, once again divided by TNF experienced and TNF naive populations in both of the induction populations. And then here you can actually appreciate that the only place where you don't see any significant difference is actually the TNF naive population. However, if you melt this together in the next graph, where you are looking at the proportion of patients with a Mayo rectal bleeding subscore of 0, and then you take a look at the dotted graphs, so the gray dotted graphs, there you see the patients who receive tofacitinib 10 milligram per kilogram twice daily in the anti-TNF failure population. That's the one below, and then the no anti-TNF failure population. So you see that they run quite close to each other as compared to the ones, to the patients who received a placebo. So, so these were the results of the Octave study. And as Peter mentioned earlier, we also can take a look at this network meta-analysis. So it's the same network meta-analysis, but for second-line treatment in UC, where you see the same setup as Peter explained earlier. And here you can actually appreciate that both in terms of endoscopic improvement as well as in terms of clinical remission, actually ustekinumab and tofacitinib came out to be the most superior as compared to vedolizumab or adalimumab, which is in the light of those post hoc analysis that I've just showed you, I think is not very surprising. And then let's just maybe step out for a second, because I think it's also important to say that comparing outcomes from different clinical trials is sometimes like comparing an apple with an orange. And I think it's fair enough to say that different clinical trials from different clinical eras have different study designs. The populations of the patients are definitely not the same. They define different endpoints, as it has all been going through an evolution in the past 20 years, first focusing on clinical outcomes and then later focusing on objective outcomes such as endoscopic remission and response. Also, the timing of the endpoints have been changing, and the use of concomitant therapy. Also, in terms of study design, and this is what you see illustrated here, that actually the first studies that came out, they were randomized studies which focused on the induction only, and then randomized studies focused on the maintenance only. And then also you have the studies where actually only the induction responders were randomized. So it's all to illustrate the differences and the evolution in study design of the past 20 years, and why it's really difficult to compare these with each other.
Okay, thank you. I think we're going to make a stop here because we have some questions from the audience that we might address. I think there was a pertinent comment from Paula Sousa about what about 5-ASA and immunomodulators, and I have to say that we are trying to focus on mostly on the new treatments and where to place them, and we didn't have time to discuss a real algorithm, but of course they have their place. And there was also a question for Peter, I guess from Seb, about some issues with the design of Varsity, if maybe they should have picked infliximab to compare with Bedo in the first place, and some other comments. Can you comment on that, Peter?
Yeah, I can. I mean, I think it's a fair question. Why not pick something else? But equally, the answer to it is why pick something else? I mean, it's a head-to-head study. You have to pick something. I guess the point is, and I guess this is what you're suggesting, is that you can't necessarily extrapolate the findings beyond the Vedo adalimumab comparison. I completely agree with that. Yeah, this is not a trial of vedolizumab versus infliximab, and infliximab is not adalimumab. And you and I both know the answer to why they didn't choose infliximab, and that's almost certainly because the study was sponsored by Takeda, and they probably thought they had a better chance of beating adalimumab, I would guess. You know, there are various sort of bits and pieces in there, and you make some points about the population, the outcomes, the fact there was a discrepancy in the outcomes in the steroid-free population. And I think they're all fair points. But the reality is that trials do vary in their outcomes, and I think we just have to see it in the whole picture. No trial is perfect, and with the retrospective scope, I'm sure it would have been designed differently. But it is an important bit of evidence, and we ought to look at it and see it for its faults as well as for what it tells us. So very important to accept those faults. Honestly, of course, one could do a whole hour on varsity if one wanted to, but I think it's an important part of the picture that we see at the moment.
Thank you.
Is that it for questions?
I mean, we have some other questions for the audience. Maybe we can touch on, there were some comments on pregnancy and Crohn's. I think we might maybe take it as a lead for the population, special populations. And let's to wrap up with colitis. How much is pregnancy or the intention to get pregnant, for example? How much is that changing or influencing your decision to pick up a second line treatment in ulcerative colitis? Krisztina, for example.
So I think a pregnancy or a wish for a pregnancy in the mid-long term is definitely something that you have to take into account when you are considering treatment options for those patients. And it's always a matter of discussion because you are trying to find a suitable treatment option for the mid-long term for them. So not for half a year and not for a year, but hopefully really for the mid-long term. And then in that regard, we know just because anti-TNFs have been on the market for very long, we have the most available data with undoubtedly with infliximab and adalimumab. So when it comes to that, we have the most available data. However, should you be in a situation where the patients have gone through many failures and have failed anti-TNF, then you would consider vedolizumab or ustekinumab also during pregnancy if the risk of relapse, which in a treatment refractory patient is quite high, is higher than the risk that you would consider with a medication. And for the moment, based on the data, based on the limited data that we have, it doesn't seem to be associated. So neither vedolizumab nor ustekinumab seem to be associated with a significant risk for the outcome of the pregnancy.
Okay, thank you. There was also some comment about the concomitant use of immunomodulators from Italy, and they were saying that they won't start with combo with maybe with some patients, but I think there's interesting data of adding immunomodulators in the second anti-TNF after failure from the paper from Xavier Roblan. Is it something that it's implemented? So when are you, in case of loss of response, let's say to infliximab, for one or the other reason, are you using azathioprine to boost before changing, for example, to adalimumab?
So we're going to talk a little bit about combo therapy later on, and indeed Xavier's paper comes into that. But the answer specifically to that question, if someone has lost response and they have lowish level antibodies, whatever we mean by that, and again, that's another webinar in itself, then I would consider adding in an immunomodulator to try to recapture response at that point. I have had some success doing that at times, yes.
If I can go more into the practical details, which I think is probably what people are interested in. In case of loss of response, let's say a woman, 32 years, left side colitis, for one or the other reason, ended up on infliximab, lost response, low TRAF levels and high antibodies, so immunogenicity in place. So we probably have 4 options available. Very shortly, what's your mental map to choose between another anti-TNF, bedo, ustekinumab, in case there are no other significant, let's say, extraintestinal manifestations or safety issues?
So it would depend partly on how good her response was to anti-TNF in the first place. If she'd done really well on infliximab, then I would think about second anti-TNF. I'd definitely give an immunomodulator with it, and we'll talk about why that is later on. If not, then any of those other options would be good. I think that my experience of tofacitinib in the post-anti-TNF space is extremely good. I would be put off tofacitinib if she was planning pregnancy. That would be a good reason not to use it. There are some other safety aspects to tofacitinib that may put me off as well if she had a history of venous thromboembolism, something like that. Otherwise, ustekinumab and vedolizumab, both very good choices in that situation, both well tolerated, and in fact I would be happy using them in pregnancy. So that would be, that's a 30-second headline of how I would see that situation.
Krisztina, if talking about tofacitinib, which I think it's obviously a very good drug. It's obviously has the advantage of being oral, and we have good data both for induction of remission and maintenance. But there is this concern about the higher risk of deep vein thrombosis and eventually herpes, especially infections, especially in the population of rheumatoid arthritis, and using 10 milligrams. If you were to start tofacitinib, how would you choose? So how would you exclude the patients? Which patients would you not give tofacitinib? Would a patient with oral contraceptives or a smoker, would it stop you from starting with it? And would you choose something else, for example?
Yeah, so I think it's a very important aspect, and I think you would have to map up how high is the risk of each individual patient to developing any of those complications, such as being an elderly patient or having a family history of VTs. And I think I would be quite put off by that. So choosing that. On the other hand, by patients who have, for example, rheumatoid complaints, who are young, who don't have comorbidities, where the risk is low, then it's an excellent drug to choose for.
Okay, we have more comments and questions, but I think we have to move on to Crohn's, Peter, and then we will try to have at least 15 or 20 minutes in the end to get into more practical discussions.
Lovely, and I've just spotted there's a mistake on this slide actually, which the more eagle-eyed amongst you might have noticed, and that's that golimumab's not licensed for Crohn's disease. That should probably be certolizumab, which of course is at least in some jurisdictions. But for Crohn's first-line treatment, we've got anti-TNF. We're very familiar with that. We have been for 20 years now. Vedo and ustekinumab both licensed here, and then of course surgery is certainly an option. So let's just look at that. I'm going to go back to Victory. Remember the propensity score matched cohort from the United States. Interesting analysis here. If I can show you, these are the outcomes here. This side favoring Vedo, this side favoring anti-TNF. But look, they've split the analysis here by disease duration, less than 2 years, 2 to 5 years. More than 5 years, and you get a feeling that anti-TNF works better in these more long-standing patients. Vedolizumab perhaps slightly better in the patients with a shorter history of Crohn's disease. So again, accepting the weaknesses of this methodology, a hint that vedolizumab may occasionally be a little bit better than anti-TNF, but we know anti-TNF is a great drug in Crohn's disease, a great mechanism of action in Crohn's disease, and a suggestion that in those patients with more advanced disease, perhaps more complicated disease, you're going to get more bang for your buck with anti-TNF. And then, of course, we're going to go back to network meta-analysis, as we have already seen, again, from Sid Singh and colleagues, in San Diego. Possibly easiest for me to direct you to the bottom here. These are the sucras again. Remember the sort of the feeling for how effective a drug is. Infliximab coming out slightly better than adalimumab, coming out a little bit better than Usti and Vedo. Certolizumab, which most of us don't use, being not too different to placebo. Again, this is for induction of clinical remission, and you have to be a little bit careful here. So in fact, this adalimumab data here is largely based on very small studies. So I think it's mostly classic, which was just a small number of patients. That was one of the original induction studies with adalimumab, because in CHARM, which was the really big maintenance study, pretty much everyone who went into that, everyone I think, had open label adalimumab. So you can't put it into the network meta-analysis because there's no placebo arm. So it takes you back to Kristina's slide about the differences between different studies and how you had to be careful comparing across them. But I think, again, useful to look at this in the entirety of the evidence. Now, when it comes to head-to-head studies in Crohn's disease, there's not much out there. Although, of course, as Krisztina said, we'll be seeing the results of CView, that's adalimumab against ustekinumab, presented both at DDW and ECHO in a couple of months' time. So watch this space because I think you'll be interested to see what the results of that are. And then the only other head-to-head study that really has any sorts of results out there at the moment is this one. I would encourage you not to read too much into this. It's a relatively small phase 2. I think about 50 patients in each arm. If I remember, and of course it's using a drug that isn't licensed yet in Crohn's disease. That's gaselkumab, an anti-P19 antibody, so targeting IL-23. Now, interestingly here, though, they had a reference arm, as you can see, and that was ustekinumab as well as placebo. There was great hope that P19 would be better than P40 in inflammatory bowel disease because that was what happened in psoriasis. This first tiny hint of data didn't really suggest there was much different. Here is the ustekinumab arm here. Here are the different gaselkumab arms. Here is placebo. So it suggests P19 works nicely in Crohn's disease, better than placebo in decreasing the CDAI you will see here. No hint that there's a major difference with ustekinumab, but as you can see, relatively small numbers of patients here. So that's pretty much where we sit with Crohn's disease at the moment with first-line treatment. But I think I'm going to hand back to Krisztina here to talk about surgery, because the data from surgery very much come from Amsterdam. So back to you, Krisztina.
Thank you. So indeed, it's been now a couple of years that the results of the LYRIC study have been published. And this was really the first head-to-head study, which interestingly compared surgery, so ileocecal resection, with anti-TNF treatment in patients with Crohn's disease with limited ileal disease. So that the limited ileal segment in patients where the limited ileal segment was not longer than 30 centimeters in total. And these patients have failed thiopurine treatment. And then the endpoint of this study, so how do you compare surgery and anti-TNF, so an apple with an orange, was quality of life. And this was measured with the IBDQ and the SF36. And then in terms of the IBDQ, what you can appreciate on this graph is that right after the surgery, there was a significant difference between quality of life favoring infliximab, which is not really surprising. However, after 6 weeks, 3 months, 6 months, 9 months, and after a year of surgery, this significant difference completely diminished. And actually patients on infliximab and after ileocecal resection did just as well in terms of quality of life. And then on the next two graphs, we are looking at the SF36, and on the first graph, you are seeing the mental component score of SF36, where you actually don't see any significant difference in any of the time points between the two treatment groups. And then here you see the physical component score of the SF36. And once again, at the right after the surgery, you see a significant difference favoring infliximab. However, if you take a look at later time points, so especially after 6 months, 9 months, and at 12 months, you actually see a significant difference favoring ileocecal resection in these patients. So that's interesting. But then I think another interesting question is how these patients are doing on the long run after the ileocecal resection. And then luckily, recently, these results have been published in Lancet Gastroenterology and Hepatology as well. So these were the long-term follow-up results at 5 years. And here you see the two treatment groups of the LYRIC study. And what you can appreciate that actually half of the patients who were in the infliximab group still had to go through ileocecal resection during the follow-up of 5 years. About 40% of the patients continued on anti-TNF, and then about 14% of the patients had other medical treatment. And then what's interesting in the resection group is that you don't see any orange color. So there were actually no patients in the resection group who got a re-resection after the initial resection during the follow-up of 5 years. And approximately 40% of the patients, so represented in gray, had either no IBD treatment or no additional IBD treatment besides prophylactic immunomodulators started after the surgery. And then about 1/4 of the patients went on anti-TNF, and about another 30% on other medical treatments. So I think these long-term data of the LYRIC study are quite encouraging, and puts also ileocecal resection into perspective as a choice of treatment in limited ileal disease for Crohn's patients.
So second-line treatment in Crohn's disease. Let's go back to the GAIN study. This, you will remember, I think, was adalimumab after infliximab failed patients. And I won't go into this in great detail, but this was a study that really showed that it was worth thinking about using anti-TNF again after the first anti-TNF had failed. Of course, it was the only option at the time, but it was terribly important that we showed that it was an appropriate treatment. Let's just look, therefore, into the difference between why people failed anti-TNF and thinking about how effective a second anti-TNF is in that situation. So this is in patients who've had primary non-response to their first anti-TNF. To cut a long story short, look at this figure here. About 30% of patients who failed their first-line anti-TNF as a primary non-response, doesn't work at all, will still get a response, but it's not great. You can probably do better elsewhere. If they've been intolerant to it, then the numbers go up to about 60%. And instead, if they've had secondary loss of response, and that will often be immunogenic, about 45%. And it's just worth thinking about that pharmacokinetic cause of loss of response. So this is a lovely study from Xavier Roblin, who's done some great work in this area, looking at the PK profile of 60 patients who'd failed anti-TNF going on to their second anti-TNF. And I'll try and do this quickly. If they already had therapeutic drugs when they failed their first anti-TNF, then they don't tend to do well. About 80% of them will have failed when they've swapped onto their second anti-TNF. If, however, they have low drug levels, either with or without antibodies, then they're going to do a little bit better. If they've had no antibodies, but they've got low drug levels, they do well on a second anti-TNF. If they had previous antibodies, they do less well. And we'll talk about that in a few seconds' time. That's probably because if you're an antibody former to one anti-TNF, you'll form it to a second anti-TNF. And then finally, if you've got subtherapeutic drug levels, but not completely absent drug levels, you will do somewhere in between as well. So it follows that algorithm I think we're familiar with. If you've got lots of drug on board, swapping to the same mechanism of action isn't the way forward. If you've not got lots of drug on board and it worked well first time round, it's going to work well second time round. This is Xavier's other paper published in Gut last year, and this is about immunogenicity, and really it just reinforces what I've just said. If you have failed your first anti-TNF because you developed antibodies and then you go on to your second anti-TNF and you don't have an immunomodulator on board, you will almost inevitably get antibodies second time around and fail. And Xavier showed this in this study by randomizing that cohort of patients either to receiving an immunomodulator when they swapped to their second anti-TNF or not receiving it. And it didn't matter whether you were infliximab first or second, adalimumab first or second, it all rang true. Because of time, I'm not going to go into that anymore, but if you just look at the differences between these curves here, and they're showing really the chance of creating antibodies and the chance of clinical failure, you see there's a big difference there. If you've got antibodies first time round, you need an immunomodulator second time round. And then finally, in this area, the network meta-analysis, and again, you can see here we're getting down to few options because it's basically an infliximab failures. You do slightly better with adalimumab and ustekinumab in this network meta-analysis than you do with vedolizumab. I think, however, as you can see, the significance levels, which are the darker bars, we're starting to get down to fairly small differences there. So I think we have to take that with a pinch of salt, and we'll be looking for more. We'll be looking for more evidence as time goes on. So I'm just going to hand back to Krisztina to finish.
Yeah, so it's challenging enough as it is for the moment, but of course we have a future pipeline of medications coming up, especially with a focus on S1P receptor agonists, on the anti-IL-23 agents, and also on upcoming JAK inhibitors, as you can see it here. So I think it's just going to be even more challenging to adequately position our treatment and even the sequencing of our treatment. So that's where I think the personalized approach is going to be even more important than ever. And then we mentioned patient profiling before. I think we could fill another talk with how to evaluate these patient profiles. But I think what we can agree on that if a patient has extraintestinal manifestations, is either pregnant or considering pregnancy, has an acute severe colitis, or in patients with perianal Crohn's disease, I think we would have a choice for anti-TNF treatment on the first place. Now, however, if it's a patient who is elderly, with previous history of opportunistic infections, or with previous history of anti-drug antibody formations, or a history of extraintestinal cancer, then I think our choice would go for either vedolizumab or ustekinumab. In terms of previous monoclonal antibody exposition, I think we have shown you some data, especially with regard to Crohn's disease, and also in proved anti-drug antibody formation, that in these patients tofacitinib would be a good choice of treatment, and that surgery in limited ileal disease could compete with anti-TNF after failing immunosuppressives. In patients with Crohn's disease. So here we come to our conclusions for this evening. So where does this all leave us? And I think one of the most important conclusions indeed is that the efficacy of the second line anti-TNF treatment is depending on the reason of switching and the reason of failure in the first place. Then based on the two nice Robland papers that Peter showed you, we can also conclude that in case of an immune-mediated loss of response to a first anti-TNF, an immunosuppressive should always be used in combination with the second anti-TNF to prevent anti-drug antibody formation. We have seen that there might be diminishing returns in the serial use of biologics. And I think the most important conclusion is that the optimal sequencing of these drugs would really consider, on one hand, drug characteristics, and on the other hand, the patient profiling, which is probably best addressed in the multidisciplinary settings. So I think with this, we would like to thank you very much for your attention, and we are happy to receive any questions that you are thinking about sending in.
Okay, thank you very much. I think we we cover a lot of ground, and there's, of course, a lot to talk about. I think we might have like 10 minutes, if we can extend 5 minutes over the time to discuss some of these questions very briefly. One thing that was posed, we're using more and more vedolizumab and ustekinumab. Do you do therapeutic drug monitoring in vedo and ustekinumab? And if you do and think about the need for intensification, how do you intensify vedo and ustekinumab?
Shall I take that? The answer is we do a little bit of vedo drug monitoring. I think the trouble with drug monitoring always relates to interpreting the answer, because there are some levels that are very easy to interpret, like 0 is an easy level to interpret, and very high levels are easy to interpret, and everything in between has a varying degree of difficulty associated with it. But the answer is yes, we do it occasionally with vedo, and for dose escalation for vedo, quite simply, we go to Q4 as opposed to 8 weekly. With ustekinumab, we have occasionally measured drug levels, but only rarely. It's not part of our practice at the moment. I don't know if you really call it dose escalation, because we rarely use the 12-weekly dose. But we do go to 8 weekly on the rare occasions that someone is on 12 weekly. We can almost never get funding for 4 weekly. And let's face it, the Stardust study didn't show huge benefits from 4 weekly ustekinumab, but we have done it on occasion with variable results, I think it's fair to say.
Yeah, I think it's really a matter of discussion, because many of those patients would sit on their sort of last line of drug choices. For example, when they have ustekinumab treatment every 8 weeks, and even those that we would do regular TDM measurement, also just because of pure sort of scientific interest, and if the patients, if there is still a benefit of ustekinumab, then we would frequently dose escalate them or reduce the intervals to every 4 weeks, which we luckily have the funding for. And on the other hand, what we could also consider is to give an IV booster of ustekinumab infusion, and then put them on 4 weekly. And then it's sort of indeed what you said with regard to vedolizumab, that it's sort of the TDM at the moment is just an additional information that you consider, which is if it's around 1 below 1, then you definitely have room for dose escalation. But actually, most of the time you would see higher concentrations in these patients.
Right. Thank you. One more question for the audience. People were asking about the use of low-dose immunomodulators, like 50 milligrams, 75 milligrams, just to prevent antibody formation. What's your take on that quickly?
There was Peter, I think, so there was another a randomized controlled study, I think, that came out a couple of years ago in APT, also from Xavier Roblen, and they evaluated whether de-escalation of concomitant immunosuppressives or stopping immunosuppressive was feasible as compared to continued dose. And actually, they showed that the low-dose immunosuppressive was just as efficient as a high-dose concomitant immunosuppressive.
I would say the jury's still out. In PANTS, the UK big anti-TNF study, they didn't measure TGNs, but they did look at dose, and they found the higher the dose of the immunomodulator, the lower the chance of getting antibodies. So there's other data out there as well, some of which argues one way and some of which argues the other. So I'm not sure that you always escape with low dose. I suspect that it varies from person to person.
So you're using full dose in case of second anti-TNF and immunogenicity, if you want to boost. Peter.
Initially I would, yes, unless there was particular reason that I was worried about full dose, in which case I may go for a lower dose.
Okay, thank you. There was a question for Krisztina about the LYRIC trial and about how to define limited ileocecal disease. What criteria you have? Because if it's always, you need to use the capsule endoscopy, MR, all of them, because we might find something with the endoscopy that might change a bit the initial.
I see where the question is coming from, because of course with endoscopy you can't always evaluate the length of the disease, so we would rely on cross-sectional imaging. For that we quite often use intestinal ultrasound. However, it's only really good if you have a very short segment of disease, because with ultrasound you can't really, if it's a longer segment, let's say longer than 15 centimeters, then you can't really give an accurate length of the segment, and then we would rely mostly on MR or CT in the minority of the situations. So cross-sectional imaging.
Okay. Quick question here about COVID and the efficacy of vaccinations and IBD therapies. Does it play any role? Are you considering the COVID vaccination antibody response to choose between any of these drugs or the drugs that we were currently using after the study in infliximab showing a little bit of less antibody formation? Any quick comment about how COVID vaccination can change your mind?
Yeah, I think it plays a very small role. I think the data are interesting. I think possibly the most interesting part of the data is that once you've had the second dose, then in fact you tend to get a good antibody response, at least initially. We'll see what happens over time. There may be a waning of response, but I think it's going to be one of the last things that drives my decision-making process, because normally there's other things. But fascinating data and very interesting question.
Okay, we have an interesting comment online on what we were talking. If you lose response to beta or ustekinumab, would you consider adding an immunomodulator?
Well, I wouldn't. I think the data, so on the vedolizumab and ustekinumab, that there is additional benefit of immunomodulators is absolutely marginal. So I think the only reason why I would consider, for example, adding methotrexate if there is a patient who's got rheumatological complaints while being on vedolizumab.
Thank you. Let me see. There was another comment on fulminant colitis. We didn't talk about that specific scenario. Do you approach it differently in the 2021 era with the new biologics and small molecules, or are we still doing infliximab or cyclosporine as usual in rescue?
Yeah, I mean, I think the question I think says second line treatment as well. And I think if the patient really has fulminant colitis and they have failed a first line treatment, then surgery is the correct treatment. There is a cohort of patients in whom you get a partial response to infliximab, and maybe you're just having to pile drug into them constantly, but they're not in that fulminant window, if you like, anymore. And we have occasionally used tofacitinib in that situation. Tofacitinib is an alternative to infliximab. Well, there's some data from Peter Higgins using 10 milligrams TDS. That's an off-license indication. I think JAK inhibitors are powerful. I think they possibly will be effective in this space. I don't think they'll be used because of the side effect profile.
Krisztina?
If there is anything to add, then because I see also a question about any updated views about rescue therapy, please. Is about the infliximab dosing and whether we can sort of introduce personalized dosing of infliximab for each individual patient. And we are currently running a randomized controlled study in acute severe UC patients, actually, where the patients are randomized either to standard dosing infliximab or to personalized dosing, where we are targeting trough concentrations in the first 6 weeks of treatment. So I think it's still going to take a while to have those results, but that's I think that's going to answer that question of the dosing of infliximab in this very specific patient population. And maybe just one more interesting update. If we are at acute severe UC, there was another interesting paper a few months back in APT as well about enteral nutrition in acute severe UC, which also showed some interesting results and benefits from enteral nutrition.
Thank you. I think we're heading to the end. Maybe one last question from the audience, and it was about rescue therapy, loss of response in Crohn's, ustekinumab versus vedolizumab. There are some data out there showing that it might be preferred ustekinumab. At least that's what our American colleagues are advocating from AGA. Do you have any preference in the, let's say, same conditions and not any special thing twisting the balance to one or the other side? So ustekinumab or vedolizumab in loss of response, let's say, to infliximab due to immunogenicity. What's your take?
Yeah, and in fact, I'm sorry I left out the propensity score analyses in that field. And there's also one from Holland. As well. I thought I put the slide in and I must have taken it out by accident. But yes, there is a hint that maybe ustekinumab is slightly better than vedolizumab in that space. And I think I do personally edge slightly more towards ustekinumab. It'd be nice to see a head-to-head trial there, wouldn't it? But you know, they're both effective, they're both appropriate. And there may be other aspects to your choice making there as well, but personally, slightly more towards SD.
Thank you very much. I think we are going to wrap up here. So with that, thank you everybody for tuning in. Thank you for your patience. We've been 7 minutes over the clock, and there was a lot to talk about, and we might need even I think a part 2 to complete all the questions that we received, and we apologize for not having addressed all of them. Thank you very much, and have a good evening, everybody.